In this video, I'll show you how adjusting clinician set parameters can affect the way volume is delivered. So, as a respiratory therapist, you can control the inspiratory time, which is the amount of time that pressure is delivered, and the rise to pressure, so how quickly the flow comes out of the machine so that it reaches this inspiratory pressure. As I said previously, the faster this rise to pressure, the faster the forward flow to the patient, and potentially the more volume you could get. Same thing with inspiratory time. Think about when you breathe in. The longer you breathe in, the more volume you're going to take in, correct? So here we have an IPAP of 15/5, which gives us a delta pressure change of 10 centimeters of water pressure. At this delta pressure change of 10, we have an inspiratory time of half of a second. That's delivering an average tidal volume of about 250 milliliters. Okay? Now if I increase the inspiratory time, so that's the amount of time I'm at the inspiratory pressure amount, it should increase tidal volume. So we'll double it. We'll go to 1 full second. Because as I said before, between half and 1 second is pretty normal for patients. So as we increase this inspiratory time, and the machine takes a little while to start calculating the volumes, but you will see an increase in the volume delivery. We're at about 350 or 300. Let's go to 1.5 seconds. So at some point you maximize the inspiratory volume. It's just like when you take a deep breath in. There's at a point where you just cannot take any more air in and it just holds the pressure in your lung. So if you put too long of an I time, you create this inspiratory plateau where you see pressure is applied, but there's no volume change for that pressure. Okay? And here we see that at about 1.5 seconds. Now we'll go back down to 0.5. And actually, I'm going to go to 1 second because that's where we got some decent volume delivery here. And then I'm going to change the rise to pressure, which can also be called slope on some machines. Okay? So we look like we've stabilized around 430, 440. Now we'll drop our rise to pressure to make the flow go in faster to half a second. So the machine's going to ramp up really quickly, hit this pressure of 15, and it's going to continue flow. And you see what happens to our volume here. Dramatically increases. Because we've rapidly achieved this pressure, and now we're holding that pressure for 1 full second. So we're having a lot of flow go into the circuit during that 1 second. The rise to pressure to 0.4, you'll see the volume go back down. And there it goes, from 500s, we're back down to 4, and we'll end up down around 450 where we were before. And the reason why we would want to adjust these two parameters, inspiratory time and rise to pressure, the rise to pressure will do that for patient synchrony. So if a patient is breathing really fast on the non-invasive machine, they're in respiratory distress, their respiratory rate's like 30, you want to match their inspiratory flow rate. So that rise to pressure, you want to be rapid to match the patient's effort, so they're not pulling back on the flow from the circuit here. Okay? So shorter rise to pressures with more respiratory distress. Lower rise to pressure with somebody who's calm and relaxed on the machine. The inspiratory time, again, that will be with the patient's respiratory rate. So the faster the respiratory rate, the shorter your I time has to be. The other time we manipulate I time is to produce a longer I time. Or when we're talking about IE ratios, get the ratio of about 1:1 or 1.5:1. And I know you know how to calculate IE ratio. You're going to have to pull that out from your previously learned material. But when you lengthen inspiratory time, it helps oxygenation. So think about it. You're taking a deep breath in and you're kind of holding it because you're lengthening your inspiratory time, and then you're exhaling. It's sort of like a sustained maximal inspiratory maneuver with an incentive spirometer, and it does help re-recruit alveoli, and it helps with oxygenation. So that's another reason why you would want to adjust I time. So not just to match the patient's respiratory rate and provide a good I to E ratio, which for normal patients is 1 to 2, but you may want to have an I E ratio that's more like 1 to 1, or even inverse 1.5 or 2 to 1, so that you can lengthen I time to improve oxygenation. Okay? So for this patient with the blood gas of hypercapnia and hypoxemia, lengthening inspiratory time will help with this PaO2 because we're going to re-recruit, we're going to hold there more. We're also going to give a lot more volume, so the CO2 will go down. So it helps both parameters at the same time. Okay? And that's just an explanation of those auxiliary clinician adjusted parameters. We will discuss them more when we go over pressure ventilation.